everybody. Thank you so much for joining us tonight. I'm Dr. Danyaal Raza. I'm the past chair of Canadian Doctors for Medicare, and we are really honored to have you all here with us for this discussion on the state of primary care in Canada. Now, before we get started, I'd like to first acknowledge that while we are meeting virtually, the Office of Canadian Doctors for Medicare is located on the traditional territories of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. Toronto is within the lands protected by the Dish with One Spoon Wampum Agreement. The dish represents the dish represents the land that is to be shared peacefully, and the spoon represents the individuals living on and using the resources of the land in a spirit of mutual cooperation. The agreement captures our responsibility not only to the land, but to one another, which I think is particularly relevant to the conversation that we'll be having tonight. You're joining us from all over the country, so please also consider the traditional territories upon which you live and work. We must recognize and underscore the significant and unjust health disparities that Indigenous people continue to face due to systemic racism and ongoing effects of colonialism. At CDM, we're committed to working to reduce these inequities as part of our work to advocate for and achieve better Medicare. Just a few housekeeping matters before we get to the topic for tonight. We're being recorded tonight, so we can share this webinar to folks who couldn't attend. Please feel free to use the webinar chat feature, send some messages out, to the other attendees, to us. Let's engage with each other. We'd love to know where you're calling in from, why you care about primary care, why this issue matters to you. You can use the Q&A function anytime while the webinar is going to submit your questions. We're going to have a Q&A portion of the evening later in the second half of our discussion. And if we can't get to the questions, we will follow up, do our best to follow up via email to the ones that we don't address. Closed captioning is also available, so please feel free to turn it on. We're going to run until about 9:15 Eastern to make sure we have lots of time for your questions. But if you have to step out early, of course, we totally understand. We appreciate you spending some time with us tonight. Okay, so let's set the stage. Let's set the table a bit. We are talking about primary care in Canada tonight, and it's no secret that the system is in crisis. 20% of people in Canada do not have a family doctor or nurse practitioner. That is more than 7.5 million people. And of course, that is not distributed equally across jurisdictions in a geographic sense, but also amongst different types of people. So for example, the lowest income people in Canada and those that are racialized have the worst access to primary care. And even if you're in that 80% of Canadians who do have access to a family doctor or a nurse practitioner, it's not necessarily to what I think many of us would consider the gold standard for primary care, and that's team-based care. So for example, in Ontario, only 20% of people have access to team-based primary care. And, I hate to keep pounding on this drum, but it's likely to get worse before it gets better. The rate of burnout amongst family doctors has tripled in 2021 compared to the previous year. And in that year, when the survey was done, 51% of family doctors indicated they were working beyond capacity. Almost 1 in 4 of our nursing colleagues also indicated that they were approaching burnout and intended to retire within 4 years, which is even a higher percentage than for doctors. When we look at the trainees coming up behind us, about 30% of medical students are choosing family medicine, but we know for a system like ours, which appropriately relies on primary care, that number needs to be closer to 50%. And of the 30% who are choosing family medicine, we also know that many are not actually going on to practice comprehensive family medicine, instead going into focused practice. So that is the state of play, as it were, and it doesn't necessarily paint, well, it doesn't necessarily, I don't need to hedge what I'm saying here, it doesn't paint a rosy picture. And of course, the problem that this matters is because the reason why this matters is because primary care is the foundation of a high-functioning healthcare system, particularly high-performing universal healthcare system. It has to be the foundation, and it has to be the front door. I think many of you already know this through the seminal work of Barbara Starfield that shows that healthcare systems place a greater emphasis on primary care. They do a lot of things better. They have lower costs, they have better access to more appropriate services, and they reduce inequities in population health. Right? But despite this body of evidence, I think many people are surprised to learn that Canada actually underfunds primary care compared to our international peers. We actually spend less. This is as per OECD data. And, part of it has to do also with the history of Medicare. As we all know, Medicare, as defined in the Canada Health Act, really provides universal coverage for doctors and hospitals, but has really failed to expand to a lot of the community-based services that are so important for primary care, for prevention, and similar chronic disease management. And it is a difficult and challenging irony, but because, of course, as many people will know, and we're going to hear a bit more about the history of Medicare tonight, that what we have today is only the first stage of Medicare, when Tommy Douglas envisioned a universal healthcare system in Canada. The second stage, which we still have not achieved, encompassed preventative care, community-based services, and chronic disease management. So this brings us kind of a bit of full circle to the crisis that I opened the introduction with. And it also, I think, brings us to a phrase that many of us hear sometimes in, politics or economics, and that's the phrase, never let a crisis go to waste, right? Whenever we're in the midst of a crisis, it always expands the imagination and the ideas to which the public and policymakers are open to, right, to get us out of that crisis. Now, that presents us many opportunities, right? There are ideas, again, that we're going to talk about later today, like school board style primary care, team-based care, that I think people are much more open to than they weren't even 5 years ago. But in crises, it also presents threats, right? Many of which we're seeing today, especially the current crisis being used as an opportunity to upturn the principle of universalism that we know is so important to access and care. We're seeing the increasing corporatization of primary care in a way that I don't think we've seen happen before in this country. So we're very fortunate to have two expert panelists to break things down for us tonight, both in terms of opportunities and threats. Dr. Lindsay Hedden is an assistant professor of health services research working in the Faculty of Health Sciences at Simon Fraser University. She is a health research BC scholar and the co-principal investigator of the Health Systems Research Lab. She leads a program of research that explores the drivers of and solutions to primary care access, and her current projects address the rapid shift to the use of virtual care, measuring current and predicting future health system capacity and demand, and examining the effects of increasing corporatization and privatization of primary care on equity, accessibility, and quality of care. We also have with us Dr. Kevin Wasko. Kevin is a former rural family physician in Saskatchewan, and now he's the chief of emergency medicine at North York General Hospital. In 2017, Dr. Wasko was the physician co-lead on the Saskatchewan Health Systems Transition Team, leading work in physician engagement, medical governance, and the academic mandate that entailed when a provincial health authority was launched. He served as the physician executive for integrated rural health with the Saskatchewan Health Authority from December 2017 until June 2022, holding joint responsibility for the delivery of healthcare services across rural Saskatchewan. And he worked to expand interdisciplinary team-based care in this capacity. So I'm going to hand off to Lindsay for a few minutes, 10 minutes or so of her opening remarks. She'll speak to some of the avenues of conversation that I outlined in the introduction. Then we'll go to Kevin, and then the three of us will have a bit of an interactive discussion, and then we'll throw it open to audience Q&A. Lindsay, over to you.
Great, thanks, Dan. So I'd like to just begin by saying that I'm calling from North Vancouver, which is the unceded and traditional territory of the Musqueam, Squamish, and Tsleil-Waututh peoples, and I'm so grateful to be able to live and work and play on these beautiful lands. So I guess today I get to be the bearer of bad news. I'm the one that's talking about the doom and gloom parts of the story, the threats. And I'd like to start by sort of framing this about the fact that the debate around privatization in our health system, both within primary care and elsewhere, is really long-standing. It's waxed and waned based on sort of how badly the health system is struggling in general, but it's really reemerged with renewed attention since the COVID pandemic. One of my mentors, a health economist, Dr. Bob Evans, he refers to these kinds of issues that health services researchers have studied for decades as zombies, where we have the bulk of evidence or answers that we need, and yet despite refutation after refutation, this debate has a zombie-like tendency to reemerge, and it's really difficult to put it down. I would also add that for as long as we've been discussing privatization, there has been deep-seated confusion. That single word, privatization, or public-private healthcare, as the CMA has been referring to it lately, really can mean so many different things with so many different potential impacts. And on the one hand, that confusion is really just a byproduct of the sheer complexity of the health system in Canada. On the other, though, that confusion is purposeful. It is leveraged. It's leveraging the complexity of the system to create confusion for reasons of fulfilling self-interest. So I really want to start by clarifying and classifying just what we are talking about when we are referring to privatization within the context of primary care, because I think the different forms of privatization have different risks, they have different drivers, and they have different solutions. And it's important to distinguish whether privatization, at the very least, is happening on the financing side, on the delivery side, or with implications for both. And I'm going to focus most of my comments on the sort of delivery side because I was asked to speak to corporatization, but I'll touch briefly on what we know about privatization on the financing side as well. So to start there, it probably will come as a surprise to no one on this call that the public-private split on the financing side in our healthcare system has hovered at around 70% public, 30% private for the better part of about 3 decades now. And when we're thinking about primary care, it's much higher on the public side, since the majority of primary care is provided by physicians whose provision of medically necessary care is covered within the bounds of the Canada Health Act. We have, however, seen rise or emergence of boutique concierge or wellness clinics that deliver primary care while also charging membership fees and or marketing services that are sort of bundled and require patients to pay out of pocket, and they're considered not medically necessary and therefore not covered within the Canada Health Act. I worked with a student a couple of years back to do an environmental scan to see how many of these we could see, and we identified 83 different clinics across the country that fell under this space of asking patients to pay privately for services or membership. And then on the delivery side, and this is, I think, the reality of where the majority of privatization in the context of primary care is happening. What's really important to start with here is that the reality is most of primary care delivery is already private. So while there is, of course, some publicly owned and operated healthcare facilities, majority of those making up the backbone of our secondary and tertiary care systems, primary care is dominated by individually owned and operated physician practices that are private small businesses. So they are run by physicians who, as contractors, bill our public insurance system, but they are private and they are for profit. This public financing, private delivery of physician services has been baked into our system since the Canada Health Act. So if that's the case, what is this privatization? Where are we seeing these shifts? And really, it is this trend of corporatization. So we're seeing a dramatic shift in the governance and ownership of primary care infrastructure. So large private equity or shareholder-owned corporations are buying out physical or healthcare infrastructure. And indirectly, through the physicians that they employ, they rely on public payment via billing provincial health insurance systems still. So it's still public payment. These corporate entities buy out existing physician-owned clinics. They're setting up clinics in grocery stores and pharmacies, and they're providing virtual care. So I'll give a few key examples. Well Health Technologies Corp is a publicly funded for-profit corporation that is now the largest owner-operator of outpatient clinics across Canada, operating hundreds of family practice clinics across the country. They also own proprietary EMR services that are used in a variety of medical practices. Loblaws, Walmart, and other grocery organizations have healthcare clinics now operating within their stores. Getting precise estimates of just how many or what proportion of clinics we are talking about is really challenging because the data are not necessarily publicly available. Where I am in BC, the Ministry of Health now estimates that about 1 in 5 walk-in clinics are now owned by a non-physician corporation, which covers about 97 different corporate entities. And then there's also the virtual care space. So a colleague of mine recently published a review that identified more than 60 different companies that offer direct-to-patient virtual care. Some offer very specific types of services. So for example, all they do is provide birth control prescriptions. Whereas others operate more like virtual walk-in clinics that provide, most primary care services, but separate from the rest of the healthcare system. So TELUS Health or Maple, for example, would fit into that category. And some of these services are public in that they bill the public system. Others bill the public system for some things, but then offer services that patients can choose to pay privately for. Others are fully 100% private. So what are the impacts of this type of privatization? I guess, first of all, proponents of the idea of parallel private financing, so patients paying out of pocket, would alleviate the burden on the public system, reducing wait times for services. But there is a huge body of evidence that demonstrates that this is not the case. Private payment may reduce waits for people who can pay, but it worsens wait times in the public system for those who cannot. And you can just look at the Supreme Court of Canada's recent Canby case decision and the evidence that they relied upon for that, just to see the sheer scope of the evidence that we have available to us in this space. And we also know, particularly from the pharmaceutical literature, that even very small out-of-pocket payments deter patients from seeking necessary care. But what about on the delivery side and this move to corporate ownership? If patients choose to go to a clinic that's operated by Well Health or Loblaws, or they access virtual care services that are owned by a for-profit shareholder-owned business and are not paying out of pocket for those services, then why should we care? Why should we worry? Proponents of privatization will claim that private for-profit ownership of delivery systems will improve the quality of care because investor-owned facilities are forced to compete for patients as business. But in reality, profit-driven healthcare delivery is associated with higher costs, it's associated with poorer population health, and ultimately with higher mortality rates. Investor-owned entities might offer special upgraded services that have no additional therapeutic value for patients other than simply generating more income to the provider, to the company, or the shareholders. And we have evidence to support that these are threats. This trend of sort of corporate buyouts that we're seeing actually mirrors what happened in Canada in the veterinary space and in the dental care space. It also mirrors trends in healthcare that we've seen in the United States, in Australia, in the UK, in Sweden, in New Zealand, and elsewhere. And research from these jurisdictions shows that for-profit corporate ownership results in increased patient volume with an overuse of profitable services that are low value, increasing healthcare spending without clear benefits. When we think about the development of the sort of walk-in virtual care that's provided by shareholder-owned corporations, it also brings additional concerns about poor quality of care, duplication, and fragmentation due to a lack of connection with other parts of the system. And also to the extent that these agencies are able to offer competitive pay or higher levels of administrative support or vacation time or reduced admin burden, these corporate-owned clinics, whether they are bricks and mortar or whether it is like a virtual care service, will present a risk of siphoning the health workforce away from other needed models of care. Finally, the corporatization of primary care delivery systems also brings with it the commercialization of patient care data. So companies that offer episodic virtual care, so TELUS, Maple, and the like, sell their de-identified patient data to corporate commercial data brokers, who then sell those data sets to pharmaceutical companies and to other buyers. And that includes public agencies or governments who otherwise would not be able to access those data. It's important to note that there is a risk in re-identification of individual patients in those data sets that's going to continue to get worse as our computing power improves. But even without that, these data are being used to enhance surveillance and marketing for very specific population segments, and they're used to market products to physicians. There is robust evidence that this practice increases volumes of prescriptions that physicians write, and it reduces prescription quality. Lastly, things like data sharing within companies. So, and the way that that's used to influence patient shopping behavior. If you go to a walk-in clinic that's owned by Loblaws, for example, they can use the data from those patient visits to send you information about products that have specific relevance to, based on your care needs. So I'll just finish by saying that corporatization of primary care infrastructure, it's here in a big way, and it's been flying under the radar. Which is really unfortunate because it brings with it a lot of risks, including risks to equitable access, including risks to the quality of primary care and of the privacy of patient data. And we really need to start paying attention to these risks in order to clear up the confusion and demand that policymakers do the same. And I will pass it back to you, Dan.
Lindsay, that was great. There's so much you packed into that, and there's so much for us to like unpack. I have so many questions, but I I will not ask all of them. Kevin, I'm really excited to turn to you because we, on one hand, need to articulate the threats, right, that Lindsay has done so succinctly and clearly. But we also have to pair our opposition with proposition, because if we don't articulate what something better could look like, then really we cede that ground to people who want to propose self-serving interests that are not in the best interests of patients, but other things like in the pursuit of profits. So you and I have worked together a little bit on Canadian Doctors for Medicare's position statement, but you have this wealth of experience as a health systems leader. Can you speak a bit to that, to the propositions that we can offer as people working in the system or people with experience in the system as patients, or as I've noticed there's some policymakers also in the attendee list who are who are actively, working on policy. What is the proposition that you would offer?
Yeah, so thanks for having me here, and I am happy to be maybe talking about some of the positive aspect. I'm currently a leader in the emergency medicine world here in Toronto, but prior, as my bio, as Dan introduced me, noted, was a rural family physician who then had oversight in terms of rural healthcare in Saskatchewan. And one of the big initiatives at the time there was to try to reorganize our provincial healthcare system into one that was really anchored in primary care, recognizing the importance, and as has been mentioned, all the literature that supports that healthy health systems are rooted in primary care and have that base. Unfortunately, we are also at a time where primary care is struggling. And I think that some of the threats that Lindsay had referenced are due to the fact that physicians don't want to practice the way they maybe have practiced in independent practices, even if they're group practices of physicians, where a physician or a group of physicians are the owners and operators of the practice. I think that as rents have become increasingly expensive and real estate is expensive. The opportunity cost of that is a challenge. There's also the fact that providing primary care is very challenging in the current state in terms of the medical complexity, the social complexity of patients, perhaps in a way that didn't occur in the past to the same degree. And for those reasons, people are wanting to work differently. And I think that our system hasn't caught up to people who are essentially walking with their feet or not choosing the profession of family practice because there isn't a model for them to work in a way that they know they'll feel fulfilled. So I think one of the greatest opportunities for us to sustain healthcare as we have known it in terms of primary care is expansion of team-based care. So this isn't a new notion that we should be working in teams, but I think it is something that has started to gain traction. Fortunately, there is a lot of talk and acknowledgement that the team-based primary care needs to be expanded, and interest from communities that haven't been as, I guess, fiercely supportive of team-based primary care are now, speaking up and calling for it, including medical associations. So I think that there is an opportunity that people are starting to get on the same page about the notion of team-based care. I think that it offers many opportunities, but I think that although people perhaps in the public hear about team-based care, they don't really understand why that would be different. What is different in a team-based model of care where people work as part of an interdisciplinary team? How is that different than the current model? And I guess what would be different is that interdisciplinary aspect of care provision. And I think that it does speak to sustainability because it has a team comprised of multiple health disciplines where the different members of the team can all work to the top of their scope of practice, and really that the needs of the patient are met with the most appropriate provider. However, I don't think that simply putting a team in place is the answer. There has to be thoughtfulness and some, science and rigor to the creation and establishment of teams based on a primary care model. Because I think if you simply randomly decided to throw a few different health professionals together and told them to become a team, I don't think the aims would be achieved to the same degree as if there was a little more thought about what the people that are to be served by the team would actually need. And I think that's why there has to be a lot of mining of population and public health data that needs to really identify who is the population that is going to be served within a defined geography by the teams of primary care professionals. And that data should then inform what the composition of a team would be. As we know, our communities and neighborhoods differ greatly, and we need to be able to adapt what it is that a team would look like based on what the population and the people that require the primary care are needing. And that is an important component of team-based care that is often not mentioned, and I think really needs to be that step back. So yes, the health system should be anchored in primary care, but primary care should be informed and established based on data from population and public health. I also think that once that team is formed, there has to be a lot of intentionality about building that team, because simply forming a group of health professionals, co-locating them in a health facility and asking them to work together in a way that perhaps none of them have ever worked before is going to be incredibly challenging. And I don't think enough focus has been given on all of the work that will need to go into creating teams so they truly are teams. we think of, sports teams or even, other entities where a team is formed. There's a lot of work that has to go into team building, and bringing people together so that trust exists amongst the different members of a team. And I think that that's no different when we form team-based primary care. There has to be some intentionality, as I mentioned, going into that. And that includes role clarity. How do we work together? What are the ways that we prefer to collaborate? And there has to be mechanisms built in on a regular basis that force the communication amongst the team members around the patients that they're serving, so that ideas are shared, people get to know each other and understand the roles that each other is playing. And I really think in the next, evolution of teams, where teams have been put into place, there has to be a real dedicated focus to ensuring that they're going to be successful. So team-based care is a solution to try to bring sustainability to our healthcare system. Health professionals are generally more satisfied when working within a high-functioning team, which is important for sustainability. But so too is ensuring that the right health professional is seeing the patient, and that health professionals within a team are working at the top of their scope of practice, so that the highly specialized member of the team is really being used to their fullest, because we know that some of those health professionals are hard to find, they're hard to train. It's something that we want access to as a member of a team, but that doesn't mean that every patient walking through the door needs to see the most highly trained member of a team either. And so this is, again, part of sustainability in that regard. And then, as I said, as we develop these teams, they should be based on population and public health data to reflect the needs of the community served. And once the team is formed, there has to be intentionality about bringing the team together and ensuring that they become a high functioning team, using best practice around change management and team building. So thank you.
Thank you, Kevin. I think whether you work in medicine or not, the importance of high functioning teams, I think we can all relate to. But of course, there's so many particular issues like scopes of practice and how we work together that are so important. I've been jotting down some questions as both of you have been chatting. Lindsay, I want to ask you in a second about the relationship between financing and delivery, but Kevin, I want to ask you a little bit about, putting a bit of a Medicare lens on this, or more of a Medicare lens on this, and a historical lens. I mentioned the second stage of Medicare, and I don't think as many people in Canada really kind of appreciate how that was not just articulated like in a policy book or a white paper somewhere, but like early on, like 50, 60 years ago, I think a community you worked in, right, Swift Current, was like a little bit of an early example and had elements of some of the things that you were talking about. I was wondering if you could, speak a bit to that as well from like a historical perspective, to kind of give us a sense of how, how long we've been thinking about doing this sorts of thing, and that it's not rocket science. A lot of the pieces of the puzzle are there, but it's about putting them together.
Yeah, so I mean, I am not a historical expert in all the detail of Medicare, sorry, but yeah, that's right. I did grow up in the region that was Health Region number 1, focused out of Swift Current, where Medicare was born. I think that that's one aspect to keep in mind, is like this notion of regionalization of healthcare is thought to have come out of the 1990s and spread across provinces, but it was actually a region within Saskatchewan where a group of communities together identified the need to provide healthcare that would be covered in terms of the hospital and physician costs, and collectively, realized that together they were stronger than any one community. And I think that that speaks to that notion of community, the importance of community in healthcare and engaging the community, and that community resources matter for the health of populations as well. And I think, as I understand, that was part of the vision that, hospital care and physician care were the expensive items, but as Medicare in a publicly provided way evolved, that there would be expansion. Back then, though, I think the notion of chronic disease management and some of the complexities that we see today probably couldn't have even been envisioned in terms of how complex people are that continue to live independently in the community, and the resources that they will need to be able to live a full life in the community, and the supports that are required. So I think that, in saying that, we have to evolve our idea of what it is that is covered under Medicare based on the fact that health has evolved, and the basic tenets of what established Medicare at the outset were universal access to healthcare that's needed. And I think that the setting and the provider is less important than that notion of medically necessary care.
Sorry to put you on the spot, Kevin, but I had to ask. Lindsay, I want to turn to you. So you framed your remarks, I think, very appropriately by defining the difference between financing and delivery, and how that applies to primary care. Now, they are distinct entities, but of course they are related too. Can you speak a bit about the relationship between the two, and how one can lead to the other or increase the risk of them, and in the context of maybe Canadian healthcare more broadly, but also particular primary care, is there one that we're more likely to see happen before the other?
So first of all, you're spot on that financing and delivery are not all independent. And actually, a lot of the examples that I gave on the delivery side do touch on the financing pieces as well. So maybe we can start there. Because of sort of provincial variability in terms of the rules around what is medically necessary and therefore covered under the Canada Health Act, because variability province by province, in the virtual care space, we are seeing differences in what patients are paying out of pocket for. So in the example of like TELUS or Maple or any of those companies, there are some provinces like Ontario, for example, where if you're not receiving a virtual care service through your regular family doctor, that it can be paid for by you out of pocket. So you can go to TELUS Health or you can go to Maple and you pay for it because it's not your regular family doctor. Whereas in BC and in other jurisdictions, that's not the case. So in those situations, you have companies that now own the infrastructure, meaning that they are the provider of the actual virtual care infrastructure. They employ the physicians who run those spaces. So it's delivery side. But in some provinces, it's also privatization on the financing side because patients are paying out of pocket for that service. The other place where I think there is some gray area is, as I alluded to a little bit at the beginning, of some of these sort of like boutique clinics. So I spoke to the financing pieces of that, and that you have patients that are asked to maybe pay an annual membership fee. That this was the case here in British Columbia recently because TELUS bought out a whole bunch of bricks and mortar clinics that were originally owned by Copeman, and they marketed them as sort of like one-stop shops for primary care, like unhurried visits with multiple different team members, sort of a very idyllic look at what primary care would be. And then they were charging sort of membership fees, and they'd sort of painted it as like, you don't pay the membership fee for your time with the physician. The membership fee is meant to cover the other services that you might use in the clinic that are not considered medically necessary. For example, you might get to go and see the dietitian, or you might have a chat with a social worker. And because those services are not necessarily captured under the Canada Health Act, it falls in this, you could argue it falls in this gray space, right? Where it's not necessarily privatization of financing because the core is still public. Patients are still able to access a physician without paying out of pocket. They were recently asked to stop, the ministry stepped in and asked them to stop this practice because what was happening is we were hearing from patients who were saying it was, if they were choosing not to pay the membership fee, you didn't have as good access to the physician. So the patients who paid could see the physician more quickly. So even though their payment isn't going to the physician per se, and it was meant to pay for these other services, it was impacting their ability to access things that were considered core as part of the Canada Health Act. So yeah, you're absolutely right that it's not totally black and white. The one other place I will point to it is this potential for sort of shunting of patients into other services that might not necessarily be evidence-based, that might not necessarily be in their best interest, but that represent a possibility for profit for some of these companies. So if you have physicians who are working for a corporate clinic who are gently encouraged to refer their physicians to see the in-house dietitian or nutritionist to give nutrition advice, even if it's not necessarily warranted, that's another place where there is public payment for the physician services, which leads to increased costs for patients because they're being pushed to see another provider that is in fact outside of the context of a publicly funded service, and they are paying out of pocket for that. Did that sort of get at what you were asking?
Yeah, no, I think so. And one of the things that you articulated was that the role that the Canada Health Act plays, and how it stipulates that you cannot charge patients for services that are already publicly insured. But as we see this creeping corporatization of care, and we see the public companies that are publicly traded who now also have investors and stockholders as interested parties, then they're going to look for ways to maximize their revenue, and then really come close, and in instances cross the line about tying the payment of uninsured services to the access of insured services. And so that's where you see where I'm also seeing the linking of, first you're seeing the corporatization of delivery of for-profit delivery of care, and then in those sorts of circumstances you're more likely to see patients being asked to pay out of pocket in more private financing.
That's exactly it. I mean, ultimately, what it comes down to is these companies would not be interested in investing in healthcare unless they see potential for a return on investment for their shareholders. Like, ultimately, that is their number one responsibility. And so they're going to be looking for any ways that they can eke out that profit, whether it's the sale of data or whether it's pushing clients, patients, families to see providers or use services that are not covered, where they are able to sort of charge whatever they want to charge for the patients to use that service.
So my next question is about barriers, both about how to break them down, but also to build them up. And this, Kevin, Lindsay, this is for both of you. When it comes to actually advancing team-based care with, like, the neighborhood school board style thinking that people are talking about more and more, how do we break down those barriers? Like, what do we actually need to do to get that done? And at the same time, how do we build barriers to stop the corporatization that we're seeing of primary care? And I know I've put the two of you in these boxes, in Zoom lingo, you're literally in boxes, but in terms of the ideas we're talking about, come at this from whatever angle that you'd like.
Do you want to go first, Kevin, or do you want me to jump in?
You go ahead, jump in.
So is it okay if I try to break down some of those boxes and talk a little bit about barriers to team-based care, or would that be stepping on your toes, Kevin?
No. Oh, so you're asking Kevin.
Or Dan, either of you.
No, go ahead.
So this is, I'm so happy to be having this conversation because, I mean, obviously the privatization and corporatization stuff is a passion of mine, but so is team-based care. I noticed somebody in the comments mentioned community health centers, which is something I'm super, super passionate about as well. So I've done a lot of work in this area. I think there are a number of barriers that have prevented more widespread adoption of team-based care. There is no one simple answer. One of the things that I really think has been intensely difficult in terms of ingraining these models so far is a lack of investment in infrastructure. So even in cases where we've moved forward in terms of our training for physicians or other healthcare professionals, and we have taught them the benefits of working in teams and how to navigate in a team-based environment, they are finishing their medical degrees and going out into a system that currently does not support that model of care. They can't go and find, like, there's only so few CHCs, so they can't sort of drop themselves into that existing place. They graduate and they're sort of told, okay, now go start your own private small business. You can find a few friends, other physicians that you know that you want to work with, but there isn't that infrastructure support to give them places to land when they finish their training. So that's kind of the first piece. The second thing I would say is just the workforce supply is a real problem. So some of the professions that we're talking about that are really, really important in terms of team-based models of care, like nurses, family practice nurses, nurse practitioners, social workers, the supply of those is not necessarily right now readily available. And so when we're talking about building new teams in primary care, those workers have to come from somewhere else in the system. So there is a bit of a training gap, particularly outside of primary care physicians, to build up those teams in several spaces. There's a lot of difficult stuff around understanding the how to make teams function, how to understand overlapping scopes of practice and work together in a way that sort of best cares for patients. But it's, Kevin, you might be much better to sort of speak to that. And then, I'm sorry, Dan, I've already forgotten what the second part of your question was. It was something about solutions to the corporatization piece.
Yeah, how do we ideally stop it, but if not stop it, at least substantially slow it down?
Yeah, so I mean, a colleague of mine, Kim McGrail, we talked about this, and her sort of response, which I really like, comes down to the best defense is a good offense. That right now these companies are moving into the system because they see opportunities for profit. They see patients who are unhappy and can't access the care they need, and they see clinicians who are working in environments that are not supportive, that are leading to burnout. So it seems like a small thing, but fix the problems in the public system, and then there's no market for the private system to kind of come in and step in. So investment in primary care, investment in primary care structure, building up supportive teams, the sort of school-based model that we've alluded to, where you within a specific geography, there's a community-based clinic that you have access to by virtue of living in that area. That uses an interdisciplinary team-based model and is very responsive to the needs of that population. So that's the first side, is really invest in and fix the public parts of the system so there's no market. In the meantime, taking away some of the opportunities that these companies have for profit, so using policy and legislation to make it not possible for them to share patient data and profit from patient data in the way that they're doing, putting more stringent regulations around referring patients to other services that they pay out of pocket for when it's attached to like a primary care visit, for example. So those kinds of sort of legal and policy things would at least be first steps to make it less profitable for these companies to be working within the system.
Kevin?
Yeah, so I think Lindsay touched on some of the barriers to team-based care, and I would completely agree. I think that there are many young physicians who would like to join these types of models, and unfortunately they don't exist, as she noted. I think that there does need to be some setting up of the examples, so it's almost like proofs of concept, where you have people that are dedicated to the notion that they've been set up in the right way. You have the infrastructure that's going to support the development of the team, which again is a challenge. So it's learning from where teams have been successful to try to do that. I think there are examples of very successful team-based care where all members are working to the top of their scope of practice, where they're collaborative, where they communicate, where patients are at the center of the care models. These do exist across the country, so it's really, I think, trying to emulate and replicate some of those models, but there has to be the will to do that. I think that, in some of the chats, there's the talk about, hospitals get all the money. I think that that's true as well. I think that as we integrate care, I think that provides opportunity to try to move towards investing in team-based care in the community, because there's the recognition that patients access care regardless. So what's going to be better for the system in terms of the cost to the system, and in terms of what's better for people, and what is making people healthier and happier and more satisfied with their care. So those are some of the aspects. But I think that when you do have a system that is not integrated, you're going to be more likely to struggle with the development of team-based care, versus in some systems that are working towards more system integration, and you have community care under the same leadership as hospital care. Eventually funding funnels up to one place, and funds can be redistributed, versus where completely separate entities are controlling hospitals versus community-based services. And that's going to be a challenge, because then you have people fighting for resources at the very top of the organizations.
Yeah, I think that's such an important but subtle a feature of like healthcare governance that you don't always appreciate until you kind of get into the guts or sit around those tables. So that thank you for pointing that out, Kevin. So there have been a number of questions that have either been posed in the chat for everyone to see, or using the Q&A function. And so we're going to get to those for the rest of our time together. And I'm actually going to hand it over to Jarol Boan. So Jarol and I have been working together as the co-chairs of the primary care working group, and it has been so great to work with her, because while I am a family doctor in Ontario, Jarol is a general internist in Saskatchewan. And so it is this sort of like interdisciplinary partnership that we are trying to role model. And I think it's worked out quite well. Jarol's been watching the questions very closely while I've been enjoying the company of Kevin and Lindsay in the conversation. So I'm going to hand it over to her to post some of the questions that have been posted by everyone listening and watching tonight.
Thank you, Danyaal. It's an interesting, I've been watching the chat. It's been interesting. Thank you, everybody, for being involved and engaged in this very interesting webinar. One of the questions I want to ask, and mainly to Kevin, but I would appreciate your views on this, Lindsay, is the distribution of human resources. We have a population in Canada that a lot of people live in the north, a lot of people are living rural. How do we distribute resources in the future to provide team-based care in these kinds of more isolated situations?
I think that's not an easy answer to come up with, but I do think that there is opportunity to become innovative when you're leveraging team, and where that becomes the norm, that people are working to the top of their scope, and that you need less members of a very highly skilled profession to be able to meet the needs of a population when you have a whole team of people. So, for instance, in a very remote place, you might have a defined number of teams, again, defined by the population data that's going to meet the needs of that population. But some of the services from, say, the physician services could be itinerant services coming into that area, because it might not be every day that their services would be needed, and that the members of the team could schedule patients to be able to be seen on a certain day and act as gatekeepers for that, because their role is defined and they can manage a lot of the healthcare needs of the population. There could also be linkages with through virtual means with health providers, again, that may be not resident in the community, but are part of the team to try to provide where possible virtual care. I think it's always a challenge, and as someone who built most of my career in rural Saskatchewan, I know that it's not always sustainable to recruit highly skilled health professionals to rural and remote areas. And that's just a reality. So if it's the reality, how do we work within that reality? And I think that, building a team around the population, relying on itinerant services and leveraging virtual care opportunities are all things that need to be on the table to try to meet patient needs.
I can jump in too. Great question. Not a question that has a super easy answer. And I think, Kevin, you did a great job of providing some of the options that we can consider on the table. I'll just add a couple of thoughts. So first is around training. We've kind of learned the hard way over decades and decades that, placing a medical school and residency training opportunities in highly urban areas results in physicians who practice in highly urban areas. We need to do a better job of offering training opportunities in rural and remote communities, and also recruiting people who live in those communities to go to medical school, because we know that those people are much more likely to return to those communities in practice, and people who train in those communities are more likely to return to those communities in practice than those who do not in either case. So that's one thing I think that we need to start doing a little bit of a better job. And we can look, the Northern Ontario School of Medicine has done a great job of addressing some of the challenges in the Northern Ontario area. And so that's one sort of model we could look to. The other is I'm aware of some really interesting work going on right now in nurse practitioner-led care, specifically in very remote, like fly-in, fly-out communities. And those models work well. So and we can learn from those and sort of port them elsewhere. So that's a second thing. And then the third and last thing I'll say is just some of my other work has focused on the sort of uptick in virtual models of care that have really been driven by the pandemic. And I think building teams where there is a network structure in place and not that every single member of the team is physically located in exactly the same space is another way that we could look at providing better resource care in rural and remote communities. We've even had conversations with some community organizations where for example, if there's a rural or remote community that doesn't have great internet service, the community center or the library even acts as a facilitator. So they will have a room where patients can come and have a medical visit or a remote visit with their family doctor, for example, so that if they don't have internet in their home, or they don't have enough of a signal that they can navigate a video call, they can go to their community center or their library and they can manage the call that way. So I guess those would be the three things I'll add.
Thank you. I guess this one is to Lindsay. Lindsay, can you comment on why such a relatively large number of primary care physicians in Quebec are opting out of Medicare completely?
Yes, it is mostly because they have slightly different rules around, I'm going to get this wrong. There's a wonderful paper that was written by Colleen Flood that was in the Canadian Medical Association that speaks very clearly to provincial regulation of privately financed physician services across the country and how it varies sort of province to province. And in Quebec, there is something specific about the way in which physicians are able to opt out and what they can charge and whether patients can purchase supplemental private insurance that makes it a much more friendly place for doctors who want to opt out. What I'm not 100% clear on is exactly what that looks like. I know it's in that paper by Colleen Flood, but in general, it's just that the rules around what physicians are able to do when they opt out and whether patients can access private supplemental insurance. Those are the two things that distinguish Quebec from other jurisdictions. I know that's not a totally satisfying answer. I'm sorry.
But if physicians opt out or disenroll from Medicare, are the patients still using public system, for example, for procedures and for radiology and that kind of thing? And
Yes.
how does that affect the distribution of resources?
Very good question. I don't know if there is a ton of Canadian research on that. I do know that there is research out of the United States that speaks to out-of-pocket payment and physicians who operate completely privately and then feeding their patients back into the public system for supplemental things that they can't provide. And we actually see it a little bit in Canada from a diagnostic standpoint also. So yeah, I think it can add stress to the system to the extent that we see sort of over prescribing of certain diagnostic tests or services that then end up being fed back in publicly when the patient has paid privately for that initial service.
Jarol, if I can just jump in there, I've experienced this. So I'm a family doctor in Toronto in a community called Regent Park, which is a lower income community, but I have patients who, run the gamut from like people who are driving taxis to people who are, working on Bay Street for like finance in the finance sector. And more than once, folks who are working on these Bay Street style jobs have gotten these executive health packages at the sort of concierge or executive health clinics that Lindsay was speaking to. And they get these low value, not evidence-based, inappropriate tests that are over testing. And when those tests are abnormal, who do they follow up with on the abnormal tests? Not the executive health physician. They come back and see me either because they're more comfortable with seeing me, which I suppose is a good problem to have, or because they're just, in many instances, they're just told to do so. And so we see this, example of, cherry picking and lemon dropping, or, privatizing the profit and socializing the risk, or public system dumping. That's another element of this. But also the other piece of this is, they get these executive health assessments and then they get referred to like cardiology ahead of other patients because they just have this more immediate access to primary care, and therefore because they have that level of attachment, they just have their degree of separation closer to all of the other services that are publicly funded.
I would just add one thing about the Quebec model that wasn't touched on, and it's I don't know how much it's impacting people wishing to opt out there, but it is a bit of a different model, but it kind of relates to the last question, because I think the intention of it is to try to address service in underserved areas, and family physicians in Quebec, when they establish practice, need to have approval to work within a geography in the province. So there has to be the need within that part of the province. So if someone wanted to live in Montreal and didn't want to have to work in, a rural part of Quebec, they may wish to opt out of Medicare and work under the private model. Whereas in other parts of Canada, there isn't such stringent rules around where one can practice. So I think, I think it has some impact. I don't know how much of the impact or how much of the issue at hand right now is due to that, but I would say that there could be some. And I think that it also speaks to why, limiting where physicians can practice could be problematic in terms of, ensuring that all, if there's shortage in the north, making physicians go to the north, like that could be a band-aid solution, or it could backfire.
The next question has to do with access to primary care. Obviously, this is a question that's come up from patients and from the general public, that they have trouble accessing their physicians. There's also been some comments in the public sector about the use of nurse practitioners, the use of increasing the number of spots for medical students, increasing the number of medical students in medical schools. There's also been talk of international medical graduates. How are we going to address the increasing burden that the patient feels of not being able to access primary care? One of the questions in the chat was about whether or not the 3-year family practice residency is necessary. Does this help with access to primary care?
I don't know, Kevin, if you'd be better positioned to speak to this than me. My feeling in reviewing the evidence that was produced about the 3-year residency is that there is a general feeling that residents are finishing their training and they feel undertrained for the nature of what primary care currently looks like and the complexities and the challenges therein. But it was a big leap for me from these people feel undertrained to a 3rd year is the solution that will address that challenge. That's just my own sort of personal perspective on that. I think that the access issues and the struggles that patients face, even those who do have a family physician, are awful and they're complex and challenging to deal with. I worry about the idea of using just an increase in the sheer number of family physicians as a lever to address those issues, because right now we're just going to get more of the same. So it's really, really inefficient. You're going to get 50% of every person who comes out of medical school and is labeled a family physician doing something that is not comprehensive longitudinal primary care. They are working as a hospitalist or in long-term care or in fact focused practice. They're doing things that are needed, that are important, but they're not going to addressing the challenges in primary care. So I keep coming back to the idea of better supported teams, investing in primary care infrastructure, having folks that can work to their full shared scope. And I think it was Dan earlier who said, or maybe it was Kevin, I'm sorry, I'm not sure, but recognizing the fact that not every single patient needs to see the most top skilled member of a team for every single thing, and that being a way of really decreasing stress. The other place I think is on the sort of tech side and addressing the absolutely monstrous administrative burden that is currently levied on to family physicians in terms of playing that role of coordinating and supporting care for their patients. And that's a topic for another 1.5 hour long webinar on a different day.
Yeah, I think the
Yeah.
recognize the 3rd year probably, the timing is not right now. Whether it will ever be right, I'm not sure. And I'm not sure, I'm not really, a proponent either way of like scrapping it or keeping it. And I'm not sure, like, I think it could be dependent on where one trains, if they feel prepared at the end, or what their training maybe looked like. I do think that years ago, even say 10, 15 years ago, residency training, the time put in perhaps wasn't as regulated, and that's true of all residency training programs in terms of people working longer hours and so on. Was that good? Probably not in many instances, the amount that residents were expected to work, but at the same time that those hours were put in a very condensed amount of time and you felt comfortable at the end of it. That might not be possible now. But again, I think it's variable, and in terms of any kind of solution to the shortage, I don't think I think it's a whole separate issue.
Dan, you're involved in a residency training program, are you not? And what do you think about the 3-year? Does it solve a problem, or should we approach it differently?
Yeah, I mean, I'll answer very briefly and then we'll move to wrap up. I think there is no doubt in my mind that is much more challenging to be a family doctor now than it was 20 years ago, and we need to adjust our training to match that reality. I don't know what the right way to do that is. It could be a third year. It's not. It may not be. I'm glad that it's been put on pause while the College of Family Physicians takes a step back, and maybe in the end of the day it will be. But clearly we weren't ready to take that step. So it's good that we've walked back from that decision, I think.
Dan, I'm going to start with you on this next question, and that is, are there examples of team-based care training for family practice residencies? And the others can chime in.
I would say every single family medicine residency is team-based care now. It is a accepted fact that is the system in which you will train anywhere in the country. So that's the standard. What is not the standard is duplicating that environment when you're done your training and you're taking care of people.
I'll just add one very short thing to that, which is I had a conversation with a wonderful colleague of mine who works at a community health center here in Vancouver called Umbrella. And they specifically support immigrant and migrant communities. And it's a wonderful CHC that uses an innovative and supportive staffing model. And she's told me so many times that she gets these wonderful residents that work with her. And the end of their term, it's always, now where can I go and work in a place like this? And the answer is nowhere.
That's very depressing, Lindsay. Kevin, do you have a response to that?
Yeah, I don't know if all family residency programs are being taught in fully evolved team-based care models. I think there are variations of it happening, and that's reflective of a primary care system in flux. I do agree totally. There are more training opportunities in the models than there are opportunities to then practice within them. That's true, but I don't know if all residents are getting exposed to what like a true great model of primary care team-based care could look like. Because I don't think there are that many examples of where it's highly evolved, because I don't think the time is always put into building the team to be effective as a team, and really having that role clarity, decision-making clarity, collaboration clarity, intentional communication. Like those things are so important, and I think often overlooked in the change management when you bring physicians who perhaps have always worked in an old model into a new model, expecting them to all just adapt quickly and start to work with people they've never worked with is not going to be a quick change.
So I'm gonna take us to the end. We're at time, and Kevin, I think that's a nice way to end, where it's not just about quantity but also quality, and making sure that we can meet both of those standards. I want to thank everybody so much for joining us tonight for what I hope was as engaging to watch and listen to as it was to sit here and take in. For questions that we couldn't take live on the webinar, we will do our best to provide answers and follow up along with a recording of the webinar tonight. Thank you, Kevin. Thank you, Lindsay, not just for participating in the webinar tonight, but for all of the work that you both are doing to help us better understand this issue, but also not just ivory towering these problems, but actually working in the real world, engaging with patients, with stakeholders, with advocates and activists to push us in the right direction. If you're a medical student, a resident, a practicing, or a retired physician, and you can hear what I'm saying right now, but you're not a CDM member, please consider signing up. Join us today. If you're not any one of these, but a concerned and highly motivated person in Canada, you can also support us. Sign up for our newsletter. We're always trying to mobilize folks towards opportunities to achieve better Medicare. There is strength in numbers. It's only by coming together that we're really going to be able to push for change that is evidence-based, values-driven, rooted in equity, and upholds the principles upon which our universal healthcare system aspires to, and we know can meet.